All right, it's 8 o'clock. Good morning, everybody. Welcome to Pediatric Grand Rounds. Today is a special collaboration with Global Health, and I'm Suzanne Mazer, Director of Continuing Medical Education here at Seattle Children's. And from here, I will turn things over to Doctors Bestie and Dr. Nielsen to introduce our speaker for today. Thanks so much, everybody.
Well, thank you. As Susan mentioned, my name is Jason Bestie, and I'm an infectious disease physician in the Division of Allergy and Infectious Disease and in the Department of Global Health at the University of Washington. On behalf of the Department of Global Health, I'd like to welcome all of you to this joint Global Health Grand Rounds hosted by the Department of Pediatrics and the Department of Global Health. The Department of Global Health believes that child health is central to the field of global health. Even before the Department of Global Health was formed, one of the foundational partners in forming the department was the Department of Pediatrics. Reuter Stapleton, for example, played an inspirational role in the development of the Department of Global Health and helped to establish the Global Center for Integrated Health of Women, Adolescents, and Children. The Department of Global Health sincerely appreciates its partnership with the Department of Pediatrics and is one of the many reasons why we are very excited about having this joint Global Health Grand Rounds. Today's Grand Rounds is particularly special because it is the first Global Health Grand Rounds for this academic year between the Departments of Pediatrics and Global Health. And we're looking forward to continuing this collaboration in the future. For those of you who may be interested in attending other global health related grand rounds with other clinical departments across the University of Washington, please visit the University of Washington Department of Global Health webpage for more information. With that, I'll pass it over to you, Dr. Nielsen.
Thank you, Dr. Bestie. Good morning, everyone. It is my pleasure to introduce a friend and colleague, Dr. Kassabaum, who will be presenting this first joint presentation between the Department of Global Health and the Department of Pediatrics. Dr. Kassabaum is a native of Washington. He was born in Sunnyside and then left Washington State for his undergraduate and medical school training before moving back to the Seattle area for his residency in anesthesiology at the University of Washington. During his residency program at UW, he joined the Institute for Health Metrics and Evaluation as a post-baccalaureate fellow to work on the Global Burden of Disease project, which he will talk about later today. After completing his residency in anesthesiology, he completed a pediatric anesthesia fellowship here at Seattle Children's, and then was on faculty at Seattle Children's until 2018, when he transitioned to Harborview Medical Center, where he continues to practice clinical medicine in the Department of Anesthesiology. Since starting his work at IHME, he has continued and really become a leader at IHME, serving as a faculty instructor for the Global Burden of Disease technical training workshops since 2013, held in Greece. And since 2016, he has been the team lead for the maternal, newborn, and child health division at the Global Burden of Disease at IHME. For these reasons, I believe there's no better person to give the first joint Grand Rounds presentation. So please welcome Dr. Kassabaum as he helps us learn more about neonatal child health and the global burden of disease.
Thank you, Katie. It's really great to have the opportunity to be here. And I think, as we were talking about this yesterday, the one take-home message that I would like you to have after this is that anesthesiologists are people too. So with that, I'll start in. For the next 45 minutes or so, 40 minutes, I want to walk you through some of the aspects, what I see as the highlights of the GBD approach to quantifying disease burden as it relates to neonates and children. Some of the things we know and some of the big challenges that are apparent, both in terms of emerging health problems and also data gaps. Disclosures, we do receive a majority of our funding from the Bill and Melinda Gates Foundation. I otherwise have no financial interest to declare. We'll first do a little bit of an overview of GBD for those who are less familiar with it, and then we'll get into talking about all-cause and cause-specific child mortality. And in this context, I refer to children as those under 5 years of age. We'll then look at some of the aspects of child and maternal malnutrition that are the biggest challenges, including child growth failure and low birth weight and short gestation. And then we'll spend some time presenting on our estimates of congenital birth defects globally. So a quick overview. First, what is the purpose? Why does GBD exist? And the reason for that is that as we all know from working in one institution or maybe a few different institutions in one city in one country, that health patterns and trends and being able to make sense of all of that simultaneously is very complex. But at the same time, it's still very important to have comprehensive and comparable information about a variety of different health problems in order to make rational decisions about where prevention is falling short, where treatment is needed, where additional research can move the needle. The Global Burden of Disease project that is centered at UW, but is really a global collaboration from over 200 countries, is the only effort in the world that does this. We now update it annually, and we'll present the information in publicly available tools in a standardized form. And it helps us parse apart some of the drivers and trends that otherwise can be obscured by macro level views. As of August of last year, there were almost 5,000 collaborators in 147 countries. We're now close to 6,000 in 165 countries, I believe, but I didn't have an updated map. What it is that is contained within GBD is it's a little bit mind-dizzying at the first. Is it's completely comprehensive. So every cause and every injury are included somewhere within GBD. These are grouped into 369 currently unique disease and injury categories, all of which have modeled estimates of deaths, prevalence, incidence, years of life lost, years of life lived with disability, and disability-adjusted life years. In parallel, there is a risk factors analysis to understand what are some of the major drivers of those. The risk factors analysis is large, but it is not exhaustive. So it's not entirely comprehensive, but even within this, there are 84 risk factors and groups of risk factors to which some of the burden of the 369 diseases and injuries are attributed. An example would be a portion of lung cancer is attributable to smoking. We do this for 204 countries and territories. 15 of them are analyzed at least the first subnational level. So that means in the US, we analyze at the US state level, in England at the local health authority, in Norway by county, Sweden, India, Ethiopia, Indonesia, Brazil, China, Kenya, South Africa, Nigeria, and Japan and the Philippines. So every country with a population over 200 million and a few additional. All of the estimates are generated by age for 23 different age groups. We're up to 25 age groups now for GBD 2020. And every time we repeat the analysis, we run the entire time series from 1990 through the present to make sure that any changes to data sources, methods, or approaches are internally consistent and reflected in the trends. And so we don't have one set of methods that was run for 2015 and another set that was run for 2017 and a whole different set of methods for 2019, which makes actually comparing difficult. The main metrics, so a year of life lost is calculated as the number of deaths at a specific age multiplied by the global life expectancy at that age. So, for example, a life expectancy at birth globally is, I believe, 86.2 years. So someone who died in the first week of life would receive 86 bellies. And life expectancy is always positive. So even people who die at age 100 are still have a positive life expectancy. So every death will count as some YLLs. Then YLDs are calculated as the prevalence of a condition multiplied by the disability weight associated with that condition. And disability weights range from 0, which would be equivalent to perfect health, up to 1, which would be tantamount to saying the disability is equal to death. I won't get into all of the methods for how disability weights are derived and all of the various adjustments for comorbidity, but there's a lot that goes around behind the scenes to adjust for those. And then DALYs are simply the sum of years of life lost and years of life lived with disability. All the data sources that are used in GBD are cataloged in the Global Health Data Exchange. This is searchable and is public. You can click on the link at the top. It would say GBD 2017 data, and GBD 2019 is going to be released next week. So this will be updated to GBD 2019, and you can search for certain sources. What I think of GHDX as is a little bit of a mixture between something like PubMed or Embase and just a Google search or Bing search if you're into that. In that it mixes literature, published studies that we've found to be useful for a specific aspect of GBD. It also includes vital statistics, health surveys, other national reports, and so it could be a good place to go to see what is the universe of information about a certain topic in global health. So if anyone's going to do a research project there, I would encourage you to put this in your repertoire. All of the results of GBD are published in online visualization tools that are updated annually. In the GBD 2019 will be coming out next week. And all of the numbers behind these are freely available for download as well. And then there's also a parallel project that synergizes with GBD for a select number of indicators, actually doing a much more fine-grained analysis and looking at up to 5 by 5 kilometer resolution maps of some indicators. In this particular case, we're looking at Nigeria and the prevalence of stunting. You see, if we only look at the national, it can obscure some very important differences and subnational disparities. So getting into the GBD 2019 results for all cause and cause-specific mortality, we actually do this analysis by age group. And I apologize, but my color scheme is the wrong color scheme. So I'll guide you. On the top here is the dark red line is early neonatal. So that's the first week of life. The blue is late neonatal. So that's the second week of life. Actually, and the other age groups cascade below that. The real takeaway from this graph is showing that the early neonatal period, the first week of life, is the period of childhood when the most deaths occur, and by definition would be the most YLLs, and also importantly has had the slowest improvement in all locations. And that's illustrated by the scatter diagrams below, which is what proportion of overall under 5 deaths were early neonatal in the year 2000. And from then to 2015, what was the amount by which the decline in deaths of that age group contributed to overall declines in under 5 mortality. And what this demonstrates is that not only were early neonatal the largest proportion but they also had the slowest improvement. After 2015, there's been a little bit of acceleration, but still lagging behind any of the other age groups. Many are probably familiar, some may not be, with the Sustainable Development Goal framework. There are a number of goals trying to integrate our human health with planetary health, with social health and equity. Sustainable Development Goal 3 is all focused on health, and Sustainable Development Goal 3.1 is focused on child mortality. The goals are for every country to have a neonatal mortality of under 12 per thousand live births and an under 5 mortality of fewer than 25 per thousand live births. And this map here shows what, based on recent trajectories and some forecasts, what is the year by which each country in the world is likely to achieve each of those targets. And what we see is most of the Western Hemisphere is on track for achieving Sustainable Development Goal for under 5 mortality, except for the north coast of Latin America for neonatal mortality. And it's really sub-Saharan Africa, South Asia, and parts of Southeast Asia that are have the furthest to go, and many are not even projected to achieve this goal by the middle of the century. If we look at the causes of mortality, these are horizontal bar charts. It's a proportion of total deaths by level 2 cause. And so the dark blue is maternal and neonatal disorders, and that is all neonatal disorders. The main contributors to that are preterm birth, neonatal encephalopathy, and neonatal sepsis. When we get into the overall group of under 5 deaths, we start seeing a much more complex epidemiology arise, where transport injuries become very important. Diabetes and like kidney disease starts creeping up. We see in many locations a non-trivial contribution of cancer, interpersonal violence, malaria, and in many places, SIDS is a large cause of under 5 death. We also did, for the first time this year, a secondary analysis of our work to try to get at one of the core principles of the Sustainable Development Framework, is that if you read the Sustainable Development Goal for neonatal and child mortality, it actually is worded in a way to say to end all preventable neonatal and child death, and then there's a semicolon said, and to bring neonatal mortality under 12 and child mortality under 25. But there's no actual definition of what preventable is. There are a number of different frameworks that have been developed for trying to quantify preventable mortality in adults, potentially as it relates to what is treatable by healthcare. Others would argue that every death is preventable in a child. I think there's also some sense that that may be not realistic, and maybe not every cause of death is equally amenable. So what we did is actually 2 versions of a secondary analysis. One, which you see the dotted line, the sort of dashed line, is what the SDG target is for under 5 on the right, for neonatal on the left. And the dotted line on the bottom is if we go through and look the entire time series from 1990 to the present and look at cause-specific mortality by age group, what is the lowest cause-specific mortality that was observed for each cause within GBD? And though overall improvement may be possible, we make the assumption that the lowest observed, at least right now, is what is theoretically achievable. And then we aggregate those for all causes together and come up with what is the theoretical minimum neonatal mortality and theoretical minimum under 5 mortality. So that's interesting for a couple of different ways. Is it highlights that a large proportion of deaths in all locations are avertable, potentially preventable. But it also highlights, when looking at this, the causes that are the least preventable. And it may not, I don't have it shown here, but it may not surprise those in this audience to hear that some that are the least preventable are SIDS, congenital heart disease, and preterm birth. The second step of this analysis was to actually try to provide a little bit of intermediate guidance and intermediate progress assessment, because it's not all that helpful if we go to Pakistan and say to the Pakistani health ministers, okay, your current neonatal mortality ratio is 43, but you should be able to achieve a neonatal mortality ratio of 1. That can be sort of demoralizing. It doesn't really give them anywhere to go. It doesn't benchmark effectively about what they might be able to achieve given the current status of their healthcare system and societal development. And so the stochastic frontier analysis is to try to look at all along the frontier of healthcare access and quality, like an overall measure of that. What are the levels of neonatal and child mortality that have been achieved? And there are some places that actually are doing really well. So Vanuatu, Marshall Islands, Samoa, Tuvalu, Tonga, many of the Oceania locations. And then there's some that have objectively similar or lower mortality rates, such as several in the Middle East, that nonetheless are not doing as well as they might expect based on the aggregate components of their healthcare system. And when we see this and we look at projections of overall progress between now and 2030, we actually see that it's possible that as many as 90% of all countries may have an outside shot of reaching the SDG targets for neonatal and child mortality with some focused effort. And then we've also generated country profiles for each, and here I'm just showing for the United States. And the US is one of the few places where improvements in neonatal and under 5 mortality have actually been consistent and balanced between one another. The top causes in both neonates and older children are the overall neonatal disorders. So those would be preterm birth, encephalopathy, sepsis, also congenital birth defects, sudden infant death syndrome, foreign body aspiration, and violence. There's been some improvement in lower respiratory infection mortality since 1990, and road injuries and meningitis rates have also both gone down. So transitioning now to looking at a couple of the risk factors. If we look at there's a handful of malnutrition-related risk factors that are quantified. Those include suboptimal breastfeeding, child growth failure, which is stunting, wasting, and underweight. A risk factor we call low birth weight and short gestation, along with iron deficiency, vitamin A deficiency, and zinc deficiency. The attributable DALYs to malnutrition have decreased a lot. In this case, I'm showing 2017, GBD 2017 results, but the story is similar in GBD 2019. But even despite that, low birth weight, short gestation remains the #1 risk factor for DALYs in children under 5. It's a third of under 5 DALYs. Child growth failure is 20%, and suboptimal breastfeeding is 3%. And if we look across all ages in the entire GBD, child and maternal malnutrition was number 1 in 1990, still number 1 in 2017, despite a 40% reduction. So there's still so much malnutrition and malnutrition-related burden in the world. So how do we approach these questions? So for child growth failure, we look at 3 different metrics in parallel: stunting, which is poor linear height; underweight, which is weight for age; and wasting, which is weight for height. So different measure of BMI, I guess. There's a lot of data in the world, and this is interesting that it's one of the places where there's actually far more data from lower resource settings than there is from high income places. We know that every child in their well child visits has a height and weight measured, but in the United States, for example, I have no idea where those data go. They seem to go into a vacuum and can't access them for analysis. The way we approach this is by modeling 3 quantities for each. First is the mean z-score, which is kind of like a standard deviation, and then the prevalence of less than -2 z-scores, which would be moderate stunting in the case of height, and the prevalence of less than -3, which would be severe stunting. And the shapes of these distributions vary quite a bit, but there's some consistency. There's not a single distribution that is going to fit it perfect, but what we found and what we've developed is a way that we can actually do an ensemble of different distribution families. So in this case, 50% weight on a log logistic, 26% weight on an inverse Weibull distribution, and 24% on a Gumbel gives an almost perfect fit to this otherwise skewed and difficult to fit data distribution. The exposures that we estimate in GBD end up then being continuous, and so we know the entire distribution, but in the end, the way we quantify them in GBD and attributable burden are actual categorical. So which proportion are mild, which proportion are moderate, and which proportion are severe. And this is because the evidence that we have up till now to quantify the relative risk of a diarrhea death given wasting is itself not continuous, it's categorical. And we're working to address this with some analysis of multinational cohort data from pregnant women and children. The outcomes that have been paired with child growth failure based on the available evidence are diarrhea, lower respiratory infection, measles, and protein energy malnutrition. And then the last part is that we only quantify this burden between 1 and 59 months of age. And that's for 2 reasons. First is that we also quantify the burden of low birth weight and short gestation, but we expect and suspect that there's actually quite a lot of mediation between low birth weight, short gestation, and child growth failure. To put a different way, many of those who are wasted at 6 months may actually be growing just fine. They were just quite preterm or small when they were born. And then the second reason, and not being able to actually parse those apart, we instead actually drew somewhat of an arbitrary line for now between the 2 risk factors, but are working toward sorting those out. And then the second reason we stop at the top end is that the evidence on the relative risk stops at 5 years of age. And so that is the furthest we can go in a manner that's supported by the data to quantify the association between poor anthropometric development and health outcomes. I'll sort of pass over the exposure, sort of covered that. And then the last is a mediation simulation. So for those who are interested, you might expect that some of the burden of stunting may not actually be stunting itself, but it's that people are underweight. Some of wasting may be that children are short. Some may be that children are not don't have enough weight gain. So we actually developed a simulation in 2013 to really is just a micro simulation of the overlap between the three different factors to try to see what is the relative risk that is likely associated with each of them, independent of the other two. And that's another area of active research now to try to understand the joint risk more directly rather than having to rely on a simulation. So the prevalence here, I'll show them, and we analyze them at the end all together, but I'll show you the results in isolation. So here is the time trend of stunting by severity in each of the regions of the world with a map of the prevalence of moderate stunting in 2017 below. Actually, this is 2019. And then show you an example of the type of data and the model result that we have illustrating the time trends on the right corner. Underweight, a similar sort of story, that there's not been a huge change in overall rates of children that are less than -1, but the moderate and severe underweight has gone down quite substantially, but remains high in South Asia, Sub-Saharan Africa, and parts of Southeast Asia, East Asia, and Oceania. And for wasting is, excuse me, lower rates overall, but these would be severe wasting or moderate wasting with edema are kwashiorkor. So that's a very serious condition that can be associated with rapid decline of. So the goal of this is to get the rates to almost zero. There are a couple of SDGs related to nutrition. One is to reduce the stunting rate by 40% between 2015 or between 2010 and 2030. And this map shows the exposure rates, the percent of attributable DALYs, and the overall attributable DALY rate. We see that there are high rates of stunting in Sub-Saharan Africa, South Asia, Southeast Asia, and a large proportion of overall DALYs are attributable to stunting, but the real attributable burden is concentrated really in the peri-Sahelian region of Sub-Saharan Africa. On the left, we see that the attributable burden itself actually improved faster than exposure. So if you recall from a couple slides ago, we attribute burden of stunting, wasting, and underweight to diarrhea, lower respiratory infection, measles, and protein energy malnutrition. That means that those outcomes have improved faster than stunting itself, which my interpretation is that is likely a ringing endorsement of the public health programs and the syndromic management and the vaccination campaigns and improvements in water sanitation hygiene that have occurred related to those conditions. The other interpretation is potentially that losing steam or losing progress on those could put us in danger of exposing a vast number of otherwise at-risk children to the health effects of those conditions. This story is similar in wasting, but in this one, the exposure in Central, East, and Southern Sub-Saharan Africa is not as much. The peri-Sahelian and just under the Sahara Desert have the highest rates, along with India. The attributable DALY proportion is more homogeneous, and the attributable DALY rate again is concentrated within Mali, Niger, Sudan, South Sudan, Central African Republic, and Chad. As for low birth weight and short gestation, I think this is an important topic. It appears two different places within GBD, which can be a little bit confusing. One is that neonatal preterm birth is a cause in the GBD cause list. So this means that there are a certain number of deaths that are estimated as being due to preterm birth as the underlying cause, and for those, YLLs are calculated. GBD has an approach much like death certificates in general, where one death can only have a single underlying cause. We also quantify prevalence by age and the associated disability for all persons who are born at less than 37 weeks gestation, but actually do have an entire distribution model for this as well. In parallel, there's an analysis of GBD risk factors where we jointly look at the distribution of birth weight and gestational age and quantify everything below the optimal level. It's a larger burden than neonatal preterm birth because, as you know, being born small or being born early is associated with an increased risk of other outcomes. This is also different than a clinical definition that is regularly used of small for gestational age. SGA is the 10th percentile for regardless of the gestational age, and a new study is called Intergrowth has gone to look at that globally rather than relying on the US-based criteria that have been present until now. But also remember that the lowest risk category is substantially higher than the 10th percentile, which is included in the estimates produced by GBD. So that's why we don't use the word SGA and don't use the word preterm, because it's short gestation and low and inadequate birth weight. So the way we actually approach this is first, we model univariate distributions at birth, birth weight and gestational age, and then use the correlation structure within the data sets where we have both of those pieces of information simultaneously to model the joint distribution of birth weight and gestational age for each location and year and sex within GBD. And then based on the relative risk of mortality in the early and late neonatal periods, we actually age those cohorts of those birth cohorts forward to demonstrate to generate age-specific joint distributions in the early and late neonatal period. So we have a picture of what was the birth weight and gestational age of that population as they age through the neonatal period. Then we've identified a number of places that have detailed information. It's follow-up data on based on the birth weight and gestational age, what is the mortality rates in those for an entire population. So we have USA, I think we have about 95 million births, and worked with our collaborators in Japan, Norway, New Zealand, Singapore, and Taiwan to help them produce similar data sets of all of the births in each of those countries over a period of 15 years, and analyze all of those together to look at the joint risk associated with each category of gestational age and birth weight. And on the left, you see sort of the resultant surface that comes out of that. And then we combine the exposure estimates with the relative risk quantification to calculate the population attributable fraction, or the proportion of certain outcomes that are likely attributable to low birth weight and short gestation. And what we see in the top left is the exposure, bottom left is the relative risk. And when we combine that, we see that there's sort of two peaks of attributable fraction. One is the very preterm and the very low birth weight is responsible for an enormous amount of disease burden. But then the second amount is actually those that are born close to term, but are low birth weight. And those that are born a little bit early but of normal weight, there's substantially less path attributable to those groups. Prevalence of low birth weight has improved in a number of places. I guess not surprisingly in some ways that the geographic distribution of low birth weight tends to track fairly well with the weight for height z-score or wasting, so that the highest rates are in the peri-Sahelian regions, as well as in South Asia, most particularly in India. On the other hand, if we look at preterm birth and extremely preterm birth, there has not been evidence of substantial improvement over the course of the study. And in fact, there are a number of locations where extremely preterm birth rates continue to increase. We see in the United States on the map on the lower left that the Southeast has substantially higher rates of extremely preterm birth than other parts of the country. And preterm birth overall is pretty much flat throughout the world. The rates are variable, as up to as much as 30% in some locations, but there's far less geographic variability or time trend in this. And I think this really highlights a gap in our understanding of what are the drivers of preterm birth, what are interventions that could prevent, what are interventions that could treat. There's a lot of effort that obviously goes into this, but at the population level, there's little understanding of what is actually effective. And then similar to the graph I showed before, the exposure to low birth weight and short gestation combined is in the top map. The proportion of all overall DALYs that are attributable is in the middle, and the attributable DALY rate, again, is highest in places in sub-Saharan Africa, along the Sahel and Western sub-Saharan Africa and parts of South Asia. And then lastly, a couple of minutes on congenital birth defects. The way that we look at this in GBD is we include all congenital birth defects that result in a live birth. And those are including those that are diagnosed prenatally or at the time of birth. We exclude stillbirths following prenatal diagnosis and exclude terminations following prenatal diagnosis in the GBD results. There are 9 different causes, subcauses of congenital birth defects, including neural tube, congenital heart, orofacial clefts, chromosomal abnormalities, musculoskeletal defects, digestive, urogenital, and other. And then the way we actually model these is breaking them down further into distinct sort of clinical entities that are more easy to understand, drivers of data, risk factors, some of the natural history. Data coverage tends to be higher in richer places or higher sociodemographic index. And the mortality data tends to be more available than prevalence data. When we look at the mortality of congenital birth defects, we see that the rates have declined over time, but the rates of decline for congenital actually lag substantially behind rates of improvement for other causes, which means that the proportion of all under 5 deaths that are due to congenital birth defects has been rapidly rising throughout the world. And the bottom left map showing that the proportion of all under 5 deaths due to congenital is lowest in sub-Saharan Africa and South Asia. Those are also the locations where the proportion of deaths where congenital birth defects are most rapidly gaining in relative importance. There's not an enormous difference in birth prevalence or incidence at birth of the various birth defects. Some of them have had pretty substantial time trends, such as neural tube defects and Down syndrome. Others, such as orofacial cleft, congenital heart disease, have been more static over time. But if we combine that static birth prevalence with improved overall survival, what we're actually seeing is that there is a rather substantial increase in the number of people living with congenital birth defects throughout the world. And again, these rates of increase are the largest in low resource settings. But even there's been an increase within the high resource, high SDI quintile. A big portion of this was due to population growth, but another large proportion of it was due to improved survival of those with the condition. And if we look at how congenital birth defects compare with other top contributors of DALYs, we see that for under 5, 4 of the top 20 most detailed causes of DALYs were birth defects, and all of them increased in rank from 1990 to 2019. Again, sort of demonstrating that these are continuing to increase in relative importance. So I'll end with just sort of a little bit of food for thought and about the directions forward in this area. Is that the history of health statistics has tended to focus on, at least at the population level, focus on trying to best understand each indicator, each condition, or each entity or problem in isolation. But when we look at maternal and child health, it's not just women, it's not just pregnant women, it's not just babies, it's not just newborns, it's not just older kids. There's really a whole ecosystem and a continuum that they're all related. And so one of my big research goals over the coming period is to start trying to actually mechanistically link all of these various factors to understand better, getting at how does low birth weight and short gestation, what are the maternal factors, the delivery factors, the exposures, and other societal factors that actually can make a difference in understanding in moving the needle on those, as well as the birth defects and hemoglobinopathies at birth. And then during childhood, how do those then project onto the concept of vulnerability when going through the neonatal and child years? And how do those relate to subsequent risk of developing infections, developing other conditions, developing micronutrient deficiencies or other nutritional deficiencies? And then even longer, how do those then project onto the likelihood that a child will be able to successfully complete their education, develop intellectually how they want to, and go on to be successful and happy adults? So there's a lot of work left to do here, but hopefully I've given you a little bit of an overview and a taste of the stuff that we've done. So thank you very much. Appreciate your attention.
Thank you so much for being here and for all your hard work on this topic and your continuing work. At this time, if you, the participants, have questions or comments, please feel free to type them in the chat with everyone box, or if you want to take a chance to unmute, you can ask your question in person. And if you end up typing it, I will read it out.
Great, Nick. Just a quick question. One of the things you mentioned was there's some small projects that have a local burden disease. Is IHME, do they have any funding to look at local burden disease, say in King County? And are there any studies around that?
So the local burden of disease project was specifically funded to look at select indicators like under 5 mortality and neonatal mortality, HIV, stunting, wasting, underweight in low and middle income countries. There was an effort a few years back to look at cause-specific mortality, and this was completed cause-specific mortality for all ages by census tract in King County. And there's also a county level analysis of all of GBD that's in year 1 of, just started year 2 of 4. So all of GBD will eventually be at the county level in the US. But there is no ongoing funding for child health in particular at local in King County or otherwise nationally. That'd be great.
From Dr. Phelps Nishiguchi. This was such an excellent presentation. Thank you so much. I would think even more than socio-demographic factors would be exploring the socio-political factors, particularly for within country variation. Is it possible to explore this? Example, structural racism, political violence, disparities in wealth and access, and how policy differences affect health.
Yeah, I think this is an important point, that there are structural components both within governance structure, gender equity, women's ability to make their women's autonomy and ability to participate in work and own land, and there's different measures of function of democracy and the additional factors you list there. And there have been a couple of analyses in the past that look at those and use a combination of those factors to try to see how predictive they are of, for example, life expectancy, all-cause mortality, cause-specific mortality, and those have been reasonably successful. IHME and the GBD project has not regularly updated those political indicators, and so we've typically just draw them from wherever they're available. But yeah, secondary analyses of that sort absolutely could be possible.
Thanks for that terrific presentation. Most of the factors listed in your last slide under maternal pregnancy also influence the childhood risks. How are you thinking about that interplay?
From a data evaluation and analysis standpoint, I'm thinking of each of those risk factors, trying to quantify and understand what is the direct risk to the mother, what is the quantitative risk to if she's pregnant, the actual course of and development of that pregnancy, and then how do those project onto some of the categorical considerations for non-communicable disease at birth, like hemoglobinopathies or sickle cell or not congenital birth defects. And then the real tricky part is about trying to and those are fairly straightforward and kind of fall within the heuristic of how we look at other risk factors, say the interaction between diabetes and obesity and high blood pressure. There's precedent for doing those sorts of mediation analyses. The trickier one is where there's not a biological link between the risk factor exposure and the outcome, about how do we approach that. And an example would be maternal exposure to, systemic racism or discrimination or socioeconomic pressures, but those all happen after the child is born. I think there's a very strong hypothesis that those would affect child outcomes, child risk factors, but how do we actually quantify that? How do we identify the data and represent that? Those those are some challenging areas.
From Dr. Trehan, inevitably, these models are only as good as the data that goes into them. How do you deal with suboptimal data? For example, COVID deaths in the US are listed at 210,000 by Hopkins and others, but estimates that look at increased year on year mortality estimate over 250,000 deaths. I believe the CDC is actually still reporting even less deaths. How do you deal with missing data, especially interested in places where people, mostly children, live and die in rural areas without access to the healthcare system or official counts?
Yeah, I think this is part and parcel of why GBD is so important, and why, uh, despite how ominous the size of the project is, that the only way to really do this with any sort of fidelity is to do everything simultaneously. So I didn't get into this at all, but actually the information that's the backbone of all of GBD is very detailed demographic assessments. So going back to 1950, looking at age-specific fertility and all the birth records from every country in the world and figuring out best estimate of how many children were born, and then looking at all-cause mortality and trying to pull all of that together to get a clear picture based on censuses and vital statistics and cross-sectional surveys and all of the information on fertility. Like, how many people are they? How many people are there? How old are they? How fast are they dying? How has that changed over time? And then using that as an envelope, going forward through all of the cause-specific death data and working sequentially through the various different biases and misclassifications and underreporting, and trying to understand and quantify and correct all of those. And so that is the bread and butter of what GBD is aiming to do. Missing data. This is why I specifically mention that all of these are modeled estimates, is that the models are trained in terms of performance to give the best out-of-sample predictive validity, and those are used to then predict places where we don't have data. So in places where we don't have data, they are predictions based on interactions with covariates and more local regional trends from neighbors with data. And then lastly, on the question on the COVID deaths, there's a sense there of there's direct COVID deaths that are due to directly to COVID. There's probably some excess deaths that may not be due to COVID. There's maybe some excess deaths that are indirect, that are for that individual had nothing directly to do with COVID. But then COVID also probably has a projection on rates of death from things like ischemic heart disease, Alzheimer's disease, other common causes of death within the older populations. And so sorting all of those out cause by cause is a lot of what the team is working on. These are methods that were developed for GBD, and so you could read about them within the appendices of the GBD publications themselves, or if you email me, I can just send you a PDF of those sections. We're working on getting it peer reviewed and published, but it's not a standalone publication yet.
Thank you so much. It is 9 o'clock, so we have to say thanks so much to this collaboration, to our speaker for his last minute filling in, and for everybody who is listening today. We really appreciate you guys and great questions, and we'll see you all next week. Thanks so much, everybody.